Thank you.
Thank you very much. I lost my voice yesterday, so I hope I will be able to make it to the last slide, so please bear with me. First of all, thank you very much for being here early in the morning. The fluids have arrived outside in Brussels. Now we're going to ask ourselves where the fluids go in the critically ill patient. So I have a declared interest. I have a company that is interested in microcirculation standing outside here. My most important declaration is I'm not a clinical doctor, I'm a physiologist. So I have a bit of a different take maybe on what you do. My interest is trying to find out what's going on, basically. So I think that's important to think when I present some of the thoughts that we have about fluids. And I'd really like to talk about what has happened in the last 10, 15 years regarding the impact of different trials and the role of the European Medical Agency in taking out starches. And I'm a strong believer that if you decide to provide fluids to patients, you should have a broad palette of possibilities for looking at the different mechanisms that you hope to address when you provide fluids. So if we would take the equal scrutiny for saline, I'm sure saline would not pass a phase 1 trial if we would do that. But of course, there's nobody who's going to give the money to do that. So having said that, I'm going to take starches into the equation because basically it's the only colloid that has been studied extensively, and we have learned a lot about how to treat hypovolemia. So having said that, I'm not a great fan of trials because I don't really think that they provide us to the information that you need, which is to know what is going on. When is it going on? Is this what I want to happen? And what is the clinical problem that I'm trying to solve? So having said those things, really physiology is the only polar star that we have. And that's why we first have to start with basics. Is why do you give fluids? What is the clinical problem that you think you are solving by giving intravenous fluids? Well, I guess, again, looking at it from the outside, that you want to treat hypovolemia. But why do you want to treat hypovolemia? Well, the idea, I guess, is that the heart is inadequately filled. It doesn't provide enough cardiac output. That means that there's not enough blood in the microcirculation with blood, which you need to provide the cells with oxygen to sustain organ function. This is, I assume, the reason why for treating hypovolemia, not dehydration, hypovolemia. Well, if that's the case, then oxygen transport is key. So now you're going to give a salty solution with a lot of salt in it, with zero oxygen carrying capacity to treat this clinical problem. And the question is, well, is that a good idea? So if we look at a lot of the papers, you see that there is this vicious cycle, that there's a hypovolemia, fluid resuscitation is given, and then you get all sorts of bad things happening. Fluid accumulation, interstitial edema, all sorts of intra-abdominal compartment syndrome, and then you have to take it out again. And this comes into a vicious cycle, resulting in fluid overload. So let us just take a look at the physiology and the mechanisms of the different fluid types. Do they really improve hypovolemia? Do they stay in the vessels? Well, they don't, at least not crystalloids. They extravagate, extensive evidence for that. Really, within about 30 minutes, it just disappears into the tissues. And if you don't pee that out, then you have all the problems that you're trying to deal with after, and you have to start de-resuscitating. So you see here that if hypovolemia is a clinical problem that you're trying to solve, then colloids are the only logical fluid to give, because as you can see in this figure, and Robert Hahn has done extensive research in that, the colloids, they stay for much longer in the circulation than do crystalloids. So this is an excellent paper by Paul Frost, I think, showing where the different fluids go into the different space. So we've got the intravascular space, we have the interstitial space, also referred to as the third space, and then of course we've got the intracellular space. So different types of fluids will distribute among these different compartments depending on their composition. So let us take a look at colloids. So there are a number of microcirculation devices that have been used, and we have used these devices to study what's really going on when you start to give fluids in the patient. Measured sublingually, you can look at the single cells and the distance between them and get a deeper understanding of what's going on. So if we look at crystalloids here on the left, and we compare it to colloids, on the right, the second movie isn't working, but you can see that on the right, the distance between the red blood cells is larger, which is exactly what you would expect from a colloid. So the distance between red blood cells become larger as the colloid takes up the space into intravascular space. And we can, with our technology, we can actually measure the difference between the two. So the crystalloids do nothing with the intravascular compartment. It just disappears into the tissues. But the colloids, they separate the distance between the red blood cells. And that translates itself a lot to the type of clinical experiences which you have, which basically has seen that you need less colloids to reach systemic hemodynamic targets than crystalloids. And if you look at the microcirculation, you see with starches that the distance between the red blood cells and the tissues becomes less. It fills the microcirculation better, resulting in a better ability for the tissues for oxygen extraction because there are more functional capillary densities. So how does this translate to what you see at the bedside? Well, one of the things, of course, is that you see that when you give colloids, you will get, here in the last sentence, a larger reduction in hemoglobin than you would with the crystalloids. So people have said, oh, well, this is the negative effect of colloids. No, it's what colloids should do because they increase the space between the red blood cells, and therefore you start to become less hemoglobin concentration than you would if you just give crystalloids, which just do nothing with the intravascular space. So it's not a bad effect of colloids, it's the purpose of colloids. So what about the interstitial space? Again, as I said before, this third space is just your interstitial space. Fluids do nothing there to improve the physiology in any way. Fluids do not have any business in the third space. And having said that, you're just going to get wet tissues, especially the kidney and the lung, and we know that extravascular lung water certainly is a bad prognosis for the patient. So if we look at actually where all these fluids go, we see that depending on the type of fluids that you have, whether they be, in this case, just albumin or normal saline, that a lot of these accumulate in the interstitial space, which is the thing here. Much less with albumin than with the crystalloids. Okay, so how does that work out? What happens then when you start to intervene because, oh dear, we have too much fluids. Now we have to get rid of the fluids. Well, one of the ways to do, maybe, is to provide PEEP. So what happens when you provide PEEP? Well, you start to redistribute the fluids. This is a study we did in Beijing with my fellow Hai Wu Hei, a very nice study on sheep, published in Journal of Applied Physiology, where we directly look at the alveoli on the sheep direct measurement, and we look at the septum. You can see it here. We can just measure quantitatively, and what you basically see is this is not a shock model of any sort. It's just to give cardiac to increase the PEEP, and you see a reduction in the cardiac output, which might be interpreted as the presence of hypovolemia, inviting you to give fluids. And what you basically then see is a septal thickness increases when you give the PEEP after fluid resuscitation, which is pushing actually the fluid compartments into the tissue space, promoting extra lung water. Mechanisms. What is going on? That's what you need to know. What about albumin? Well, albumin is very interesting because it makes use of osmosis. So what happens? Now, this is a study which we did in which we were able to actually measure quantitatively the occurrence of edema. So what we basically do is we measure the focal distance of the microcirculation with the surface, and we validated this in urogynecological patients, and we can exactly say how much edema or tissue space is between these. We applied this technique in burns patients. If you want to really study burn fluids, go to the burns patients. They get liters of the stuff. 25 liters is not unusual. And they have this strange formula called the Parkland formula, in which they first load the patients with crystalloids, and then afterwards in the second phase go on to albumin. And you see very nicely that if you do that and you look at the focal distance, that when you give crystalloids, you see an increase in the third space. All the fluids just go into the tissues. But because burns patients can also have got good kidney function usually, they pee it out again. So it's not that bad as in our septic patients. If you then give albumin, you see that you're very well able to reduce the edema in the patients. So my last couple of slides, I'd like to show you a trial that we did in cardiac surgery patients, asking this precise question: where is the fluid going? We used 3 techniques: non-invasive cardiac output monitoring with the NextFin. We looked at the microcirculation, and then we used bioimpedance to look at the distribution of the fluids in the interstitial space and in the intracellular space. That's the secret space, intracellular space. And this is how bioimpedance works. We used a lot in nephrology, unfortunately not so much in critically ill patients. It's a very interesting technique. And what you see post-operatively is indeed you see an increase in cardiac index, which is exactly what you would expect if you give a lot of fluids. If you look at the microcirculation, however, you see that you've diluted the microcirculation. So increasing the cardiac index has a negative effect on the circulation, is that you dilute the oxygen carrying capacity of the microcirculation by diluting the red blood cell mass. If you then look at the bioimpedance data, you see something very interesting. You see an increase in weight. People get heavier, so they're accumulating fluids, and you see an increase in the extracellular water, i.e. the third space, which we know already, but interestingly enough, you see a decrease in intracellular water. So you have an extracellular overhydration at the expense of an intracellular dehydration. Crystalloid resuscitation causes intracellular dehydration. And that's not something that I invented. There are many studies done in the 60s, looking at, the 1990s, looking at radioactive with stable isotopes, labeled water, and there they have also found already in septic patients a decrease in the intracellular water. And the interesting thing is that intracellular dehydration causes protein degradation. So here we have an intracellular hit by crystalloid resuscitation. And this is another study done later showing exactly the same thing. Here you see that the amount of extracellular water to intracellular water increases dramatically at the expense of when you use crystalloid resuscitation. And here too, you see extracellular water going up post-operatively at the expense of intracellular dehydration. Last 2 slides are just a comment on the glycocalyx. That too, there are studies, even though Nate did not show that, but there's some evidence that glycocalyx degradation occurs. And my last slide is salt. Why do we never talk about salt? In 1 liter of sodium chloride, there is 9 grams of salt. If you have a patient, and I looked at the slides that Nate showed, liters and liters of the stuff, and you would ask your residents to eat the salt that they're giving to their patients, which is an average of 50 grams of salt. That's a lot of bag of chips, I can tell you that. And this is very interesting studies being done in the nephrology community in which they're asking the question, what does salt do? And this is my last slide. It increases the vascular leakage. What salt does is it accumulates in the glycocalyx, and it causes degradation of the endothelial cells, resulting. These were done in healthy volunteers. And the salt that they eat, their high salt is like a pizza a day. It's not that much salt. And Yucatecala said a couple of weeks ago in a conference in which I was, physiology doesn't need trials, and I would certainly applaud that.